Hello, this is a case of CTO intervention of the RCA using retrograde reverse card. Chronic total occlusion refers to a coronary artery that's been closed for more than 3 months. It's fairly common on coronary angiography that shows disease, with about 20% of these patients having at least one chronically occluded artery. It's difficult to treat traditionally with the usual methods of angioplasty. And it's the common artery that's most likely not bypassed at the time of the surgery for multiple reasons, including it is usually underfilled and thought to be too small to bypass. Hybrid algorithm was developed in the past decade to simplify the approach to CTO intervention. There are really 3 ways of tackling a CTO. One is in an antegrade way using a wire escalation, whereby multiple CTO wires are used to traverse the CTO from true lumen to true lumen. The second method is a dissection reentry method, whereby the CTO is approached via dissecting into the subintimal lumen proximal to the proximal cap and re-entering distal to the distal cap. And the third method is really retrograde fashion, whereby the donor collaterals are used to traverse the CTO from a retrograde fashion. Which method to use depends on the nature of the CTO, which includes the length of it, the appropriateness of the distal target for dissection reentry, or the appropriateness of the interventional collaterals, as well as the ambiguity or lack thereof of the proximal cap. This drawing shows in a simplified fashion the methods we use. On the left, as you see, the first wire is advanced into the subintimal lumen from the proximal cap. On the right, the antegrade wire has gone through to through via wire escalation method, and the same drawing also shows a retrograde wire which has been used to traverse to the distal cap from the donor collaterals. Now let's go to our case. It's a CTO intervention using retrograde technique, specifically utilizing reverse controlled antegrade retrograde tracking technique. These are the patient's characteristics. He's a 54-year-old gentleman with multiple risk factors for coronary artery disease, including hypertension, hypercholesteremia, who's an active smoker. He presented with exertional angina and was noted to have a large reversible defect in the inferior region. His cardiac catheterization showed double vessel coronary disease with a severe LAD lesion and a chronically occluded distal RCA. He underwent stent placement to the LAD but continued to have symptoms, and a CTO intervention was attempted utilizing antegrade methods unsuccessfully. He was referred for retrograde CTO intervention. This is our setup shot showing the occlusion to be more than 20 millimeter in length, with a proximal cap that's not ambiguous, but a distal cap that it's at the bifurcation of the RCA and the PDA, making this a good retrograde case. This is our cranial shot showing the third and fourth septals in the mid to distal LAD to have favorable angle for entry and exit into the PDA, making this again a good retrograde case. And our caudal shot again showing favorable angles for the third and fourth septals to be used for retrograde access. Here we have successfully served the septal artery and accessed the PDA from the retrograde guide, which is a 90 centimeter EBU 3.75. The turnpike LP has been successfully maneuvered into the PDA. Here our wire has been changed to a pilot 200. In this case, we were not able to penetrate the distal cap with the Pilot 200 and therefore scratched it with a Hornet 14 before switching back to Pilot 200 to traverse into the distal cap and into the lesion. Here, we switch gear to the antegrade guide. A spiral turnpike and a Pilot 200 are being used to penetrate the proximal cap, which was not that difficult since the proximal cap had been worked on a few weeks before. And now the antegrade wire is overlapping with the turnpike LP. Therefore, we're getting set up for reverse cart. An 8-French guide extender is advanced to the site of the proximal cap in order to do so. Reverse cart is being performed with a 3.5 times 50 mm balloon with the retrograde wire being switched from Pilot 200 to a Hornet 14 in order to penetrate the antegrade space once the reverse cart is performed. Reverse cart has been performed and the retrograde wire, namely Hornet 14, is advanced into the guide extender. Once the wire is advanced into the guide extender, the microcatheter is advanced over the wire into the guide extender and the wire is exchanged to a long wire, namely an R350 in this case. The long wire is then externalized, and once it is externalized, we have created a rail upon which angioplasty can be performed via the antegrade guide as shown here. A gentle contrast injection via the antegrade guide shows resumption of the antegrade flow, and we can establish our landmarks for stent placement. A 4.0 by 32 mm drug-eluting stent is placed, followed by a proximal stent placement using a shorter stent with overlap. Once the final stent is placed, the retrograde wire is removed, the microcatheter is removed, and these are the final angiograms before terminating the case.